Good evening and welcome to my YouTube channel, Pain Free Partha. Today I'm going to talk something about perioperative arrhythmias. And welcome to my institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry. Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar. Now, whenever I get this problem of writing, arrhythmia, so A plus rhythmos, actually it is arrhythmia, but actually 2 R's come here. So whenever I type arrhythmia, there is always a red line in it. Another problem is actually arrhythmia means there is no rhythm, but it is mentioned for the term dysrhythmias. It has become colloquial to mention arrhythmias and dysrhythmias because arrhythmia means no rhythm, but in practice it is not that. So the incidence of perioperative arrhythmias is 30%. You have to do like that because we are talking about so many things like malignant hyperthermia, thyrotoxic crisis, and all the incidents are extremely rare. But this perioperative arrhythmias is less talked about. Routinely, perioperative arrhythmias is taken as patient factors, anesthesia factors, surgery factors, type sinus bradytachy, PPCs, atrial fibrillation, SVTs, bigeminy, and what are the drugs for control. This is what is routine, but I am going to see in a different way. Now, my experience is about a perineal abscess. So, perineal abscess, what is that they told? But planned to give ketofol, but heart rate came down to 35 to 40 per minute, and they have done the manual anal dilatation without informing us. So normal heart rate is 60 to 100. Never bother about 55 or 50. My case is 55. My case is preoperatively only 52. All these things are not there. Normal heart rate 60 to 100. Anything below 60 is Brady. So what are the clinical scenarios in which you get Brady? Squint surgeries, sometimes thyroid surgeries here during dissection, puerperal sterilization when they take up the tube, DNC, dilatation and curettage. So when they dilate the internal arms, these are all called distal parasympathetic reflex or Brewer-Locard reflex. Laparoscopy during inflation also and sometimes deflation also. Fundoplication, they are close to vagus. Tourniquet, all neurasthenial block, sympathetic block, reverse Weinberg reflex, and you get bradycardia. So the basic treatment is used to stop stimulus. For example, thyroid means stop stimulus. Squint means stop stimulus. Oxygenation can give atropine. There's a deadly combination. Many people use fentanyl, dexamethasone, and vecuronium. We see the heart rate is 48. So many times, what I do after regional anesthesia, we get these things. So I do a grip, that is sympathetic stimulation. The heart rate picks up. Not only the heart rate picks up, in neuraxial blockade, we know the level is well below the risky things. And we know that the BP is quite good enough, like at least 90 systolic, to understand this and do this. So these are all the advantages of doing this tight hand grip for Brady. Sometimes we get the spine surgery is done, no? Sometimes we get arrhythmias, bradycardia, hypotension. Many times we see during GA. So this what is so is dural traction is the cause, was the possible cause. Immediate post-tonsillectomy after some time. The 12-year-old uneven full surgery, heart rate goes up to 20. Normally, what PGs or residents do is give paracetamol for a tachycardia. The heart rate rise again when the patient has swallowed 500 ml of blood and he is not vomited, and it is this blood is not explicitly found outside, so they don't know whether the patient has blood or not. So always better to have hand on the pulse. We know what is arrhythmia, we know what is the normal pulse, we know how much it is different from the normal pulse, all these things if you put a hand on the pulse. Hypoxia can produce tachycardia and sometimes very bradycardia in the late stage. Laryngoscopy can cause intubation, can cause bradycardia or tachycardia. And we all know, should know, that extubation can also cause arrhythmias, because during intubation there will be a lot of people to help. 5, 6 people, and during extubation, nobody will be there. A 42-year-old male, type 2 diabetes, occasional wheezer with vomiting for GA surgeries, develops VPC after GA. So now you have three problems. Type 2 diabetes, occasional wheezer, vomiting. This vomiting can cause hypokalemia. This wheezing, sometimes salbutamol, can cause hypokalemia, and insulin can worsen this hypokalemia. So these are all the clinical scenarios. We get hypokalemia and also start getting VPCs. Now this is our article. ECG changes in normal. You can see the WPW syndrome is around 4.5 to 5%. Normal, no problem. Healthy patients, no murmur, nothing. This is sometimes they can cause tachyarrhythmias during the labor or during cesareans. Abdominal retractor can cause arrhythmias, especially when the open cholecystectomy days. The second assistants used to put this retractor like this and lift it without seeing the field. So all these things can produce arrhythmias. A chest tube can touch the atrium. So I don't know whether this is a surgery or anesthesia or anything like that, but this can produce brady, tachy, VPC, every other arrhythmia known almost. So dangerous things. So that is what is ECT. So whenever there is an ECT, we should be ready to face many arrhythmias. An atrial fibrillation, because you need an atrial kick, hemodynamic deterioration can cause. Atrial fibrillation prone for thromboembolism. There will be impact in the ventricular filling. All these things, AF can produce some sort of unstable hemodynamics. See here, there was one case, mitral valve replacement done. We did around 3 to 4 weeks ago. This was atrial fibrillation was doing. After I put the internal jugular vein to start, this atrial fibrillation disappeared. I don't know what I have done with this. So AF disappeared. So I have touched this. So sometimes touching may be beneficial, but most of the times touching somewhere will produce atrial arrhythmias. Beware of obstructive sleep apnea syndrome. This night hypoxia, some problem in the atrium, some problem in pulmonary hypertension. Yes, definitely prone for arrhythmias. So history of OSAs, we are prone for arrhythmias. Guide wire induced arrhythmias. A 35-year-old healthy 80 kg male, I gave this before the USC urea. 25 ml of 0.5% bupivacaine with 30 ml, and there were a lot of conduction blocks, bradycardia, hypotension. Slowly the patient became unconscious. Thank God, we put the tube and patient pulse BP, IV fluids and ephedrine. Patient came back. No, there was no arrest at all. And we did the surgery, and this was diagnosed as last later. All type of arrhythmias, conduction defects, hypotension can occur with local anesthetic, systemic toxicity, or last. Many times we see ST, but we don't see QT. Corrected QT more than 450 milliseconds, which is coming like this, beware. They are prone for arrhythmias. Choline itself, succinylcholine itself can produce bradycardia and arrhythmias. But once, before, previously, short surgeries, what we do, they do tonsillectomy within 10-15 minutes earlier, 20 years ago. We put the tube with choline and sometimes they finish within 10 minutes, so give another choline again. So that is the problem with all type of arrhythmias. We think that the cardiac arrhythmias is none with ondansetron. Now you see, ondansetron and the risk of cardiac arrhythmias, a systematic review and post-marketing analysis. I have gone into IV peranostetron many times. So this is our article. A peranostetron IV is little better than this ondansetron in relation to whatever it is in this cardiac problems. We thought that atropine neostigmine can cause arrhythmias. It's not like that. Yes, sugavandex can also produce adverse effects on the cardiac rhythm. We all know this is the action potential. And class 1 is sodium channel blocker, class 2 is beta blocker, class 3 is potassium channel and class 4 is calcium channel. So it is sodium, beta, potassium, calcium, and others like adenosine. Here, this is a sodium, that is where it acts. So sodium, potassium, ATPs. What does it act? Digoxin. Pulse oximeters, capnography, ECG. Whenever you ask anybody, they'll tell this. ASA monitoring standards, all these things, and sometimes invasive also. But nobody tells about the surgical field and blood loss. And many times, this pulse oximeters may not work, or sometimes arrhythmias may present whenever they use cautery. Certain types of arrhythmias like tricuspidal, second degree, complete heart block, new onset branch, left bundle branch block, AF, SVT, all these things, yes, we may need to wait and do the surgery, postpone it. This is the type of arrhythmia, atrial fibrillation. I am not going to go how atrial fibrillation look like, how an atrial flutter look like. That's a different, absolutely different topic. Rate control with beta blockers, rhythm control with amiodarone. Same thing, flutter. Rate control with beta blockers and rhythm control with amiodarone. PVCs don't need to worry at all. Very rarely we may need some low dose beta blockers. VTAC, yes, amiodarone and lignocaine. There is one cause of VTAC, but we should not use lignocaine. Sometimes VTAC can occur even after last local anesthetic systemic toxicity, where lignocaine is contraindicated. Unstable, do a cardioversion. VF, yes, defibrillation. SVT, we know adenosine and beta blockers. Bradyarrhythmias, go for antropine. So this is the main simple way of treating arrhythmias. We always should say, as perioperative physician, treat the cause. Whatever be the cause, hypokalemia, treat the cause. Manipulation, treat the cause. Whatever it is, treat the cause. Now we have an 19-year-old female posted for bilateral breast tumor, completely unevolved GA. And after that, the surgeon described the case over, and we were about to extubate. The heart rate went up to 160, BP to 50 systolic, lot of arrhythmias, phenylnephrine and ephedrine. We don't know what has happened, but only what we have given 2 minutes before this episode was we gave ondansetron. We thought it is an ondansetron allergy, but many times it is idiopathic. My physician used to tell, idiotic on the part of physician and pathetic on the part of patient is only idiopathic. What is the message I want to give? Keep surgical manipulation at minimum and give good deep anesthesia, good analgesia. Treat the cause and see the hemodynamic status. Prevent hypoxia, hypotension, hypovolemia, hypothermia during surgery. This is very important. Many times we see this, whether it is AVNRT or AVRT and all, just give to normal fluids, put some ephedrine. Many times the rhythm will disappear. Post-operative follow-up is important because I had one case breast surgery done and I went to see some other case. By the time there was ECG taken for this case, and they were discussing so many things about this, what should cause bradycardia and arrhythmias. Then I went there to the level of umbilicus, the bladder was there. I put in the catheter, all arrhythmias, all tachycardias settled down. So treat the whole patient and not the ECG alone. So normally cesarean section under spinal anesthesia, baby is delivered, and after that what they do, sterilize the uterus. That will cause tachycardia, bradycardia, arrhythmias. Then they'll put a mop inside and do the uterus care like that. Then after that they'll push the uterus out and do the full mopping of the abdomen, and all type of arrhythmias can come, which is beyond the scope of even this textbook. And thank you all. Visit me at Pain Free Partha YouTube. Thank you all again.